I'm going to go ahead and get started. My name's Julie Pitty. I'm a speech pathologist at University of Virginia Medical Center. I work there full-time, but I spend one day a month in the Huntington's Clinic at the Center of Excellence at UVA. And we're going to talk about the role of the speech pathologist with patients with Huntington's. So my goal for patients and families is that safety, comfort, and quality of life. Those are my three main goals for y'all. So we're going to start with, what is a speech pathologist? How can speech pathologists help you? Swallowing difficulties and strategies to maintain a quality of life, communication and ways to improve it, and signs that it might be time you need to get some help with a speech pathologist. I think it's unlike physical therapy and occupational therapy. I don't think it's as intuitive to people that a speech pathologist might be helpful, because you might not be having any trouble swallowing, and your speech might be just fine. But in reality, I think a lot of times people are having a lot of trouble that they may not be reconciled to. In our clinic, we have a speech therapist, me, an occupational therapist, a physical therapist, and we all work together to, again, keep people safe, comfortable, and preserve a standard of quality that you would like to have. So it's very much me talking to patients and asking them, how can I help you? A speech pathologist, in case you've not run into one of us ever, has a master's degree in speech pathology. We assess and treat people with swallowing difficulties. We assess and treat people with language, voice, and cognitive difficulties. We work in various facilities. We can work in hospitals, skilled nursing facilities, schools, acute rehab centers, and specialty clinics such as the one that I work in, the Huntington's Center of Excellence. We also work with people who've had strokes, head injuries, progressive neuromuscular diseases such as ALS and Huntington's disease. About 90% of what I do in the hospital where I work as an acute inpatient speech pathologist is swallowing. So that's my main focus. That's my passion, frankly. So again, like I just had said with this is what we do, this is how we can help you. We can assess swallow function. We can assess speech, language, and cognition. We can offer guidance for safe and comfortable swallowing. We can make suggestions for efficient nutrition, assist with effective communication, and just offer general support. And that's a lot of what we do. So the assessment of the swallow function, it varies, and I'm talking here a little bit more about what I do in the hospital, but it's the same sort of thing at the clinic, except for one difference. During the assessment of a swallow function in the clinic, I often do the interview. I want to find out what kind of trouble you're having, if you're having any. Oftentimes patients say, no, I don't have any, but their spouse is next to them saying, yes, they do. I don't think it's necessarily something that people are really aware of, and that's usually the case in any sort of marriage situation. Somebody notices something so annoying about the other person that the other person has no idea they're doing. So anyway, we do a lot of talking first about how you feel during meal times, Are you coughing or choking? Those are the two main questions. Or strangling. I found out when I moved to Virginia that that's the word people use for choking or coughing. If yes, you are, then we need to find out what. What are you choking and coughing with? Is it liquids? Is it solids? Or both? Is it all the time, every time you eat? Is it just at dinner time? So we've got a lot of questions to ask and answer. Then we do an oral motor exam, which is all those questions, all those things I have you do, that you stick out your tongue, pucker your lips, puff your cheeks up. We want to make sure that your cranial nerves are functioning, and to what degree. We love to get a voice and cough sample because we want to make sure it's nice and strong. We do a breath support measure, which is the sustained ah, and we ask you to do that for as long as you can on one breath. And then the articulator agility, so that's the tongue and the lips, and just trying to determine how they're moving. Are you coordinating your movements? Now, in clinic, we don't do food trials. I wish we did, and I think we should. But for some reason, the way the clinic is, we haven't been doing it that way. However, people who come to the clinic often spend 2, 3 or more hours in the clinic by the time they've seen the doctor and seen the psychiatrist and all of the therapies. So they oftentimes bring a snack. And on those days, when those people bring snacks, I love it because I get a chance to see how people are actually functioning when they swallow. Oftentimes, or not very often actually, sometimes we'll recommend an instrumental swallow exam, which is a dynamic x-ray of a swallow, because the way people talk about their swallow and complain about their swallow, they cough all the time. We need to see what's happening, where the breakdown is occurring during the swallow. And as you'll see on my next slide, there are a million places and ways it can break down. Everybody's different. So sometimes I'll recommend that we do one of those instrumental exams just to see where the food is going, what the path is of the food or liquid. So in a normal swallow function, and I use that term loosely because there's a wide range of normal, but there are 3 phases of the swallowing function. The first one is oral phase, and that's chewing and forming a bolus, which is to say that you're going to take whatever you've put in your mouth, move it around, chew it up, your tongue moves it back and forth, side to side, and then you're able to send it back to the back of your throat where a swallow reflex can take place. The pharyngeal phase is where the swallow reflex takes place. It's the back of the throat. Just if you look at that picture where the teeth end, at the end there, that's about where we want the, well, a little lower, at the tongue. It's where, let me just, can I show? Right here, when the food gets to that spot, that bolus that you've created, that's where we want the swallow to start. But we also know many people with normal swallow functions don't swallow until it gets much further down, but that's where we like to have it start. And the rest of the pharyngeal phase is to move the food to the esophagus. The airway is in the front. It's that first tube that's in that picture. And we don't want anything going into the airway. And that's what makes people generally cough, because that's your body's natural reaction to something going into that airway that shouldn't be going. The esophageal phase is not something that we look at it. We don't necessarily study it or determine anything from it other than that it might be impacting the rest of the swallow, or the top part of the swallow might be impacting it. but we don't necessarily do much with that except watch the food go from the top of there's a sphincter at the top of the esophagus, and we like to see that sphincter open nicely, the food come through, and all be gone. That's in a perfect swallow. Some common swallowing difficulties that you all might experience or know somebody who does is poor oral coordination of the tongue and the lips. So if you have oral chorea, your tongue doesn't necessarily function as well as it should to create that bolus that I talked about. It's that very coordinated chewing and tongue movement to create that ball to go down. Incomplete chewing or moving the food to the back of the mouth, so you might not chew as well, and or be able to have your tongue push it to the back. There's another holding food or liquids for a long time prior to your swallow. That's as dangerous. It's a little concerning because the longer you hold something in your mouth, the more likely you are to lose control of it. Drooling or food falling from your mouth. Incomplete swallowing, leaving food residue, so you've swallowed, but when you open your mouth, there's still food in your mouth, across the tongue or in the teeth or in the pockets. Impulsivity and difficulty controlling the amount of food or liquid intake. A lot of times I hear from family that somebody says they say they're packing their food in or just getting it in there. Well, the more food you have in there, the harder it is to move it around and get it into the back where it needs to go. So in coordination of swallowing and breathing, because the oral mechanism does three things: we eat with it, we breathe with it, and we talk with it. So we have to breathe with it. We can breathe and eat with it, but breathing, talking, and eating with it is all at the same time is very dangerous. And then good old just not paying attention to what you're doing. A lot of people don't. A lot of people take their swallowing for granted, and then you add some of the cognitive difficulties that you're experiencing, remembering what, the task you're attending to or needing to attend to, can cause some problems. So some of these are things that go haywire because of new behaviors, but some of them are just anatomical things aren't functioning well. So those were some of the swallowing difficulties. Here's some signs that you might have swallowing difficulties: the coughing and strangling or the choking. Wet sounding voice after swallow. I don't know if anybody has ever heard that, but it's something to really listen for, because if you're sounding wet or like your voice changes after you're swallowing, it could mean that things are going into the airway, which is trying to breathe rather than receive food and liquids. So wet breath sounds, it's the same sort of thing. Frequent throat clearing. Now, we a lot of times have that habit. A lot of people have the habit of clearing their throat a little bit. So it's hard to know if that's something to worry about or not, but it's definitely something if you hear it a lot. That's one of those things spouses tend to pick up rather than somebody, the person themselves. If you're losing a lot of weight, that's a sign that you might be having difficulty swallowing because you're not efficiently swallowing your food, or you're not eating enough because it's not comfortable anymore, but you might really not be aware of it. It might not be something that you're in tune to. So, but if you do notice that you're losing a lot of weight, and that's one thing to think about: is my swallow working okay? Frequent congestion. If you're constantly coughing, like a congested cough, or you're getting pneumonias or sick a lot, that might be something, meaning that aspiration is occurring. Coughing when not eating, I hear this a lot. And that's usually saliva mismanagement or the inattention to saliva. So you're not swallowing because nothing's entering your mouth, so you're not swallowing saliva. Whereas most people swallow all day long, a little bit at a time. You're not feeling, you feel the saliva, so you swallow it. Some people just forget. So you just have to look at that too. Generally, safe swallow guidelines, first thing I have people do when they come to clinic and their initial visit, and I ask them if they have swallowing problems, and they say, no, not really, I eat fine, and everybody agrees they're eating fine. I suggest keeping a journal of any time that you do have an event or an episode of choking, just to sort of keep track. It's a good way to you want to put down, like, what was I eating? Where was I? Was the TV on? Was that the time when all the kids were home? Just kind of to keep track, because it might be an isolated event and it's nothing to worry about, or it might be the start of something, but we want to make sure that we're keeping track and understanding what's happening. Keeping meal times predictable, that's kind of one of those same times, similar situations. That's because people with Huntington's disease like predictability. Sitting upright with head support if needed. A lot of people are they might be in wheelchairs now, and we all know wheelchairs don't have a lot of support for the back of the head, and there are some that do, but if you need that. Reducing distractions, I think that's probably one of the biggest and easiest things you can do to make your swallow safer immediately, is to turn off the TV, keep conversation to a minimum. Not that you can't talk while you're eating, but just making sure that you're not trying to do all those three things at the same time. Using a straw is great for people who have reduced oral control with liquids, because if you are tipping the cup up to swallow, that can it does exactly what you don't want to have happen inside your throat. That actually will open your airway and close off your esophagus. So you want to make sure that you're keeping your head in a neutral position when you're swallowing. So straws, perfect. Those bendy straws are awesome. Or a cup with a lid or a little sippy top, that works too. If you're having trouble getting the food to your mouth, and an occupational therapist speaks to this better than I do, there are lots of utensils that people can use to, they're weighted maybe, so that reduces the amount of this, and kind of you have to hold something a little bit heavier. And then using plastic dishes with a rim helps too, so you're not chasing food all over the place. If you're a fast eater, one of those people who's just shoveling it in, it's a good idea sometimes to just put your utensil down in between in between bites, so that you're not just shoveling this way. Now, are you going to remember to do this? Probably not. Is your spouse or your caregiver going to remind you? Probably. But and a lot of the responsibility for safety is placed onto the caregiver, and just reminding. And then you can cough every once in a while if you feel the need to just kind of clear things off, just in the event that something might be going down the wrong way, but you can't really tell. So if you feel like there's something there, definitely cough, but it's not. That cough every few bites to remove residue is generally something we see on a modified barium swallow test, that we can see you're not clearing and you're not feeling it, so we might ask you to cough in between. It's a good strategy if it's necessary. And then to help control that saliva that might not be getting swallowed like it should be, just to keep water with you with you all day long. Just kind of sip it from time to time. It's good for you, and it might just help you remember to swallow that saliva. Diet modifications some of these are really easy to do. You can cook foods a little longer to make them softer. I forgot to say this at the beginning, but most of what I've learned has come from my families who've said, oh yeah, I've tried this and I've tried this, and I'm like, yes, can I use that in my talk? Because y'all have got a good handle. You've been watching people with this disease for generations, some of you, and you've seen it. But using leaner cuts of meat, casseroles work really well because it's just all right in there. It's one consistency generally. You can chop foods or finely grind them. I think that most people probably do that, so that takes the chewing out of the food. So because if chewing's your difficult piece to eating, then you want to essentially chew it on the plate by cutting it up rather than chewing it in your mouth. You can add gravies, sauces, and condiments. I love the idea of mayonnaise and butter and sour cream and ketchup. Anything to make your food that might be dry or hard to swallow a little moister and a little bit easier. And then sort of as a last resort, I think, for me anyway, is pureeing foods. I think that's probably one of the things that people resist for the longest time. There are a lot of foods that are puree consistency without being pureed, such as your hot cereals, oatmeals, and cream of wheats, and yogurt, and that consistency is wonderful. And there are lots of foods that are like that already. Mashed potatoes. And then so then again, adding high-calorie, nutrient-dense foods to the blender. So soups and shakes are perfect in the blender, and you can get a lot in there. And then you're eating a creamed soup rather than something that doesn't appeal to you. Thickening liquids, if you're coughing consistently with thin liquids, and I mean every time you put a liquid in your mouth, you might want to consider thickening them with a commercial brand thickener, Thicket or Thicken Easy. But I don't recommend doing that unless you have really good evidence that that's going to be better for you, that that's going to actually be easier to swallow, because nobody likes to drink thick liquids. It's just not, it doesn't necessarily change taste, but that texture is just kind of not great. So, and the way you can, when I say unless there's evidence, I mean from a modified barium swallow test that you've had or something, because it could be that it's just, it's your swallow's to the point where it's not swallowing anything really easily, so it's kind of hard to know unless you've had the test. And then my favorite is swapping hard foods for soft ones. I had a patient come into clinic last month, and she said her husband was having a hard time with his Oreos. And there's really nothing you can do with your Oreos except maybe dunk them in milk, which is always delicious. But we talked about swapping them out for some brownies or, changing that sweet treat that he was really enjoying. And she liked that idea, so I think he was all for it. So safety and comfort while swallowing. Number one, so important, is oral care. Keeping your mouth clean. Clean, clean, clean. Because if you're sending things down the wrong way, it's likely to go in, if it's going into your lungs and you've got a lot of bacteria in your mouth. We all do, but we try to remove it a couple of times a day. We can kind of reduce the amount of dangerous bacteria that might go into your airway. And it's just better for you to keep your mouth nice and clean. And if you have dentures, or no teeth, just brushing, keeping clean. And here again, I say modify diet as a last resort because people really like their food and no one likes to have it changed. And I prefer to try behavioral strategies before we change diets. Understand the risks of aspiration, which is sending foods or liquids down the wrong pipe. If you choose to eat, and most people do because it's something that we all really like to do, but we know that you're having a hard time swallowing, we know that things are probably going down the wrong way, just know what you're looking for. Because aspiration it can cause an obstruction of your airway, or it can cause bacteria to get into your lungs and cause a pneumonia. So we want to just, if you know that, and you know that going into, I'm going to eat anyway, and that's you should. You should be able to eat if you want to. But just understand what that means if things are going down the wrong way. And then, preserving a quality of life. People want to eat their foods, and you have a really hard time as caregivers watching somebody eat whatever it is, because it just looks so darn scary, for lack of a better word. I think a lot of times people get scared when they're watching people eat and they know they're choking, but sometimes you just have to let them do it. And I'm off my soapbox now. So I'm going to switch to communication and staying connected, because that's what a speech pathologist does. We do swallowing and we talk about communication. But before I go on, does anybody have a question about any of the swallowing difficulties that you right at the moment? Yes.
When the phlegm collects in the throat, and my daughter kind of talks through it, and I keep wanting to say, your throat, and I don't want to insult her, but is there any way to is that the only way to get that out of there? I don't know why it's left. Is that a swallowing issue? Or?
Mm-hmm. So the question is, if phlegm collects in the throat and they're talking through it and you can hear it, that's that wet vocal quality I was talking about. It's also that saliva buildup that I'm talking about. So yeah, you can definitely say, hey, you need to clear your throat. That's an okay thing to do. Absolutely. She doesn't hear it, but you're hearing it. So go ahead and ask her to clear her throat, but also, and I don't think people get really annoyed by that so much. Do you find her getting annoyed at it when you ask her to? Yeah, well, I think do it, because you know what? You don't want it. What's happening is that picture I showed you of the mouth and the throat. The vocal cords are like the last defense before everything falls into the airway. So she's just building up on top of her vocal cords. And so that's why her voice sounds wet. So if she blows it off with a throat clear, it's going to blow off. She's going to swallow and it's going to go away. So she can keep that watered bottle with her to remind her to swallow. But yeah, clearing, you can make a little fun out of it. Just go yourself, just however you want to do it. But yeah, good question. Mm-hmm. So the question is, how often does a person's swallow need to be assessed? Is it every time they come to clinic? Yes, we do it every time they come to clinic. We definitely ask the questions, are you having any changes? Because if somebody, was fine 6 months ago, because in clinic they come every 6 months to a year generally. And so a lot can happen in 6 months to a year. Things change. Even though this disease can take years from start to finish, things can change pretty rapidly, like overnight. So yeah, we definitely ask the questions. How are things going? What's going on with your swallowing? And then if they say nothing, then I don't do an assessment like that so much. I'll just, just keep talking a little bit more about the journal and has anything happened and stuff like that.
So like my daughter, she's on
Uh-huh. Yeah, I think that's reasonable. Definitely. Mm-hmm.
Regarding oral care, as brushing becomes more difficult and to the point that perhaps the caretaker is assisting with the process, certain toothbrushes, rinses, techniques, tips that come to mind that help with that process safely?
So regarding oral care and tips for safety and losing the ability to brush teeth, we've recommended the electric toothbrushes. However, the regular old Sonic Care, the really expensive ones, generally there's too much of a, like it really is bothersome on teeth a lot of times. It's annoying to people. The battery operated ones are less so. So I like a cheaper just Oral-B toothbrush is probably.
I use a spin brush.
Yeah, that's the one the spin brush. And rinsing, I think even just rinsing with water but mouthwash certainly, if you can do it. And, a lot, it's not very comfortable, but if you have to do it for somebody, you have to do it for somebody. Any others before I go on to communication? Okay, so stay connected, and staying connected is so important. And engagement from both communication partners, the listener and the speaker, is necessary for effective communication. I don't know if you've all noticed, but sometimes people with HD tend to sort of withdraw almost. They just kind of don't talk as much as they used to. And just going with that can cause problems because they might start to feel depressed, frustrated, or isolated. So you want to develop and facilitate communication with your partner. And fortunately or unfortunately, to achieve effective communication, the listener must consciously accept the responsibility for the conversation exchange. I think that's really important to realize that. I know it can be frustrating for everybody. So the communication components, we have our speech, which is articulation, breath support, and phonation, and coordination. Language, there's talking and hearing and understanding. And there's understanding's the key. If a person can hear, they're hearing you, but they may not understand anything that you're talking about. And then cognition, which is attention and memory and reasoning and problem solving and sort of muddling the way through a conversation, being able to stay on task. So speech production difficulties and intelligibility, reduced breath support, which I hear fairly frequently, produces a hoarse, sort of harsh, strangled vocal quality. So it's kind of like this, but with reduced breath support. So inappropriate rate, rhythm, and pitch of speech, the person tends to go too fast, or they go too slow. They have a monotone or inappropriate stress on words. So it's kind of, there's really no sort of this is how it is, because there's so much variance to people's difficulties. Imprecise articulation is just the unclear pronunciation of sounds. So that's sort of that people often say slurring, but that's the slurring. I'm not very fond of that word. Strategies for increased speech intelligibility. Slow down. One word at a time if you have to. Try to get a rhythm. You can tap it out if you want to. Shorten your utterances. So a lot of times people come out with just this big long sentence and they just, nope, shorten it. I need my hairbrush. Just keeping it short and slow. Practicing breathing exercises. I left a handout at the back on one of the chairs for some breathing exercises that I have found useful with patients. It's actually helpful for when people are coughing too, because when we cough, we tend to do and that's just pulling whatever's in your in that area down into the airway. So we want to reduce things like that. So the breathing exercises not only help the speech, the respiration and breath support, but they also can help you, if you do them, fairly consistently, understand that when you need to cough, you can just do it a little bit more through your nose and not bring a big breath in. To improve imprecise articulation, we try to have people use bigger mouth movements during speech. So a lot of times when people are slurring, it's because their mouth's not moving and it's harder to understand them. But if they move their mouth and they have a little bit of extra breath support and they're talking a little louder and slowing it all down, they can get the resonance to be a little more as it should be, and then we can understand them a little bit better. So my reference to move that tongue, purse those lips, let's go, move it, purse them, practice it by doing the ooh and the e and the o. So a lot of language and cognitive skills, these are some of the difficulties, some of the things you might see. Initiating conversation, getting words out of your thoughts, bringing the thoughts down into the words. Limited ability to respond in conversation, word finding is often part of the problem. Difficulty understanding complex information, that's that inability to really grasp what somebody's talking about. Difficulty learning new information, poor short-term memory, poor attention and concentration skills, reduced organizational skills, and reduced ability to reason and problem solve. A lot of this is the same thing I just talked about with the swallowing, but it also comes into play when you're trying to communicate. And then, I'll just read these to you more on cognition. Huntington's is a degenerative brain disorder. These difficulties occur randomly as the disease progresses. The unpredictability can be frustrating for the person with Huntington's disease. And as a caregiver, it's important to understand that the person with Huntington's has no control over this. They're not being stubborn or consciously choosing to not remember to do something that you've asked them to do 100 times. So strategies for effective communication for speaker and listener. And this is pretty much just for anybody, anywhere, at any time. When talking to somebody, it doesn't help if you're in the kitchen, they're in the bedroom, the water's running, and the TV's on, and you're calling out to, hey, get me the, I don't know what, but that's a problem. If you want to converse or need to tell somebody something, get their attention, tap them on the shoulder, get in the same room with them, look at them, and make sure they're looking at you, and then start your exchange. You, again, speak slower. You might need to repeat the message or ask them to repeat the message and ask them to slow down, and that goes both ways too. Rephrase the message. You can simplify the message, so you might want to take things down a little bit. But remembering that in any conversation or communication exchange, the main goal is to get the message across. So you just want to do whatever it takes. So you can use yes/no questions, and a lot of times as people's communication progresses to where they're really having a hard time being understood, you can make a broad to specific decision tree. So you might start with the big broad topic, are you hungry? And then instead of saying what would you like, you can give 2 options or a few options, and then just bring it down. Oh, you want Mexican food? Okay, do you want to go to this place or that place? Or so bring it on down closer. You can rehearse common conversational exchanges, so daily activities that you need to happen. You can rehearse them and get through them. Monitoring perseverative behavior, that when are we going 400 times, and the 400th time you can say, we're going to change topics now. We're going to talk about X. Allowing adequate time for communication is huge, because we're all in this, everything's in a rush these days. We want everything right now. We want an answer right now. And there are times definitely when you need an answer fairly quickly, but allowing adequate time to let somebody speak and get an answer is very important. Again, reducing distractions. Doesn't help, like I said, to have water running, appliances going, can't hear. Using gestures and facial expression, that's part of making sure you're in somebody's view too, is you can see from somebody's facial expression whether they're angry or upset or happy. And if you're really having trouble getting what's happening, you just at least try to get the main idea of what's going on. And that goes both ways. Either give the main idea, like the decision tree, the broad topic, or get the main idea by just asking something along the same lines, and keeping the environment predictable. So it's always harder to have lots of people running around, family, sometimes, kids, people who are making noise and talking. That gets really hard to communicate in. So this is assistive communication. I'm not really well versed in this, I must admit, but there isn't a ton of it that really helps much. I think smartphones and tablets can help, emailing and texting. I know of several of our people who come to clinic have phones that they text even from room to room. There's one girl who's always on her telephone. Her family was sort of complaining at first, but now they've gotten on board and they're texting her back. So that's how they've been communicating. And her mom even made her like a little holster for her phone so she won't lose it, and she's got it with her at all times. I think that's a really great thing if you can do it. Texting and email is not something a lot of people are comfortable with. There are a lot of communication apps out there, and I just don't know of many that are really widely used with patients who have Huntington's disease. If somebody else does, I would love to know. The low-tech sort of device is just a reminder notebook. Post-it notes are wonderful. Calendars, memory books, so pictures of things and that people can relate to, communication boards, things that have maybe I want to, and have some pictures or written words if reading is still something they can do. Communication boards are used, and they're so easy to make, they really are, because you just make them to fit your person. I had a thought. So when to contact a speech language pathologist about any of these things or any concerns you might have. I say the earlier the better, before there's a problem even, just to establish a plan as the disease progresses. I think that's why clinic is so great. I don't know if you're all going to any sort of clinic situations, but it's really a wonderful place to go, and you get all sorts of support from the variety of therapies and doctors, and we can monitor how things are going and give you some help before you need it, rather than when you're in the middle of it and you don't know what to do. Or if you aren't going to clinics or you don't have access to anybody who can kind of help you along with these things, when you begin to see changes in communication, so speech is harder to understand, or you're saying the same thing 4 times and it seems like somebody's not understanding what you're saying. So either one of those. And swallowing, if there's a lot of coughing or choking or you're starting to hear those things, that's definitely a time to get there. Again, change in dietary habits, like you notice that your spouse isn't eating as much as they used to, and you can't really get to the bottom of why, because they may not understand why they're not eating as much, but it might be because it's not comfortable, and naturally they're just sort of thinking, I don't want to eat anymore. And then definitely weight loss. But also, I didn't say this earlier, but if you're feeling, so if a person gets a pneumonia, like, and you've been noticing them coughing and choking with meals, it could be, that they've got a pneumonia from their swallowing. So some of the things to look for in that department are like if a fever, they develop pneumonia. Those are sometimes things, go to the doctor first, but then let's address it with a speech therapist to sort of work that out. And my references, does anybody have any questions? Any other questions? Yes.
I heard about a program for Parkinson's, big speak
Big and loud?
Yeah, big and loud.
That, yeah, it's
Is that something you know about or recommend?
you could try it, because it's definitely breathing and breath support exercises. Get you louder. I had a good friend who has Parkinson's disease, because that's what it was developed for. Because, well, anyway, and I have a friend who has Parkinson's disease, and he went and he said he thought he damaged his vocal cords because he was so big and loud that it didn't work for him. So it's just kind of, it might work, and it might work for you because you have a very soft, we've talked about that before, and you're soft-spoken. So big and loud might be good. You know what? I kind of feel like anything's worth a try. Yeah.
I had gotten my daughter an iPad, and I did get some feedback from some of the social workers
Uh-huh.
for HD to try these different apps. I'd be glad to send them to you.
Okay. Yeah, I'll give it to you. Uh-huh.
You mentioned that you don't do the swallowing evaluation in clinic. Is there a reason that it's just too time-consuming?
It can be. You mean the food trials? Because we do everything else but the food trials, unless they've brought a snack or something. Yeah, no, I would like to get that started. It's just, historically, it hadn't been done, so I don't.
How much time do you need to do that, just curiosity?
Oh, not very long, 10 to 15 minutes. And I think it's good just to sort of see, as rather than calling it an evaluation, just sort of a screening tool to see, like, do you need some speech therapy? Because we don't provide outpatient speech therapy at the clinic. I mean, we do all the talking, and I give strategies and tips, but real therapy is not done there. So we would have to find somebody to go to, so. Any other questions? All right, well, thank you.